Hello. Welcome to another in a series of programs produced by the Missoula Peace Network. My name is Deborah Franson, and I'm the moderator for today's discussion on the Montana Senior Citizens Association's drive for legislation to provide a national health care program for all the citizens of the United States. It includes a single-payer system for the payment of health care and coverage for basic health care, including long-term health care. Today we have with us Doug Campbell, who is president of the Montana Senior Citizens Association, and Dr. Pat Hennessy, member of Physicians for a National Health Program. Welcome.
Thanks.
Sure.
First of all, today we'll be seeing a video called Crisis, which highlights the current crisis in American healthcare, both in access to services and in cost.
And the first time you get up, make sure that one of the nurses or with your mother or someone is watching, because you're still going to be grabbing some medication. You still have a lot of medication in your system.
Story in this half hour of All Things Considered.
From ABC, this is World News Tonight with Peter Jennings.
Good evening. Tonight, money and medicine on the American agenda.
As healthcare faces a collision course between cost containment and costly medical advances that might save lives, money, not medical opinion, may call the shots.
Chicago has lost 4 of its 10 trauma centers. In Dade County, Florida, every hospital has dropped out of the trauma network except one. One trauma center for more than 2 million residents.
Right now we have a disaster, and we have to respond to it the way we responded to Hugo and the earthquake.
During the busiest periods, paramedics talk of medical gridlock. They can't even unload their ambulances because the emergency room is full.
Patricia Sweeney thought she was fully insured for the health care she needed when breast cancer struck. But ABC News reported that the insurance company wouldn't pay for the operation Patricia Sweeney's doctor believed might save her life.
Now she's dead, and I will never know if she would have had that treatment if she would have lived a long time.
It may be that the real question about America's healthcare system is whether life and death decisions should be made by 1,000 different insurance companies, each one driven by the need to produce profits.
More and more, it appears that only the rich can afford some kinds of treatment. Some of us, like Patricia Sweeney, will die.
There is now a 3-month wait for scheduling urgent procedures like biopsies and CAT scan x-rays for heart, cancer, kidney, or gynecological diseases.
This is the James M. Jackson Memorial Hospital in Dade County, Florida.
The wait is 6 months for serious but less pressing problems.
There are higher co-payments, higher deductibles, family coverage is being denied or it's being reduced. And this doesn't even get to what is an absolutely critical problem, the problem of long-term care.
Ron Pollock is a leading expert on the economics of aging. He's executive director of Families USA Foundation.
People who are considered higher risks are being denied coverage, or the costs are so extraordinarily high that people can't afford to pay for this coverage.
The people who have adequate health insurance don't realize how precarious their situation is.
Dr. Gilbert August is a pediatric endocrinologist.
The companies are getting far more restrictive now. If your employer decides to change the healthcare insurance carrier, you could be in trouble if you have a chronic disease, because that new health insurance policy may provide a 6 to 12-month waiting period for pre-existing conditions. And so if you have a child with, let's say, diabetes, who isn't going to be covered for diabetes for 12 months because of the waiting period for pre-existing conditions, then you're in a situation of playing Russian roulette.
Rick Reckoweg is an electrician. His wife, Sandy, stays home to care for their 3 children. Rick makes a decent wage. Through his union, his family has what he thought was a good health insurance plan.
Health insurance, I felt fine. Never gave it a second thought.
Didn't have a care in the world.
Yeah, didn't have any cares about health insurance.
They felt certain that their insurance policy protected their child, Jeffrey, who developed breathing difficulties shortly after birth.
We discovered that when he was 3 weeks old. He stopped breathing while I was holding him. My husband and I both tried to get him to breathe again by shaking him, and he finally started breathing.
A birth defect in Jeffrey's brain stem causes him to stop breathing when he falls asleep.
Jeffrey spent basically his first 19 months at the hospital. By the time that Jeffrey was 11 months old, his $100,000 lifetime limited policy was used up.
Jeffrey is now 8 years old. During the daytime, he's a bright, active child. He plays soccer, and he's a Cub Scout.
This is my All-Star plaque, the first time I was in the All-Star game from spring 1989. So at the end of the game, I forgot if we won or lost, but everybody got a plaque. And that season, I was playing my fullback. Now in select, I'm playing on my halfback, wing, and fullback.
But at night, it's a different story.
We sat and quite literally performed CPR on him for well over an hour. And during that time, you get tired, but you don't react emotionally. It's afterwards where you start realizing what just really transpired, that you just went through.
Jeffrey still requires constant care. He still needs to be hooked up to a ventilator all night, every night. All this is emotionally devastating to a family. It's also financially devastating.
The last time that I checked, we owed them $600,000 from back bills, because there was a period of time from 11 months until he was about 4 years old, where he had no insurance whatsoever, nor did we qualify for Medicaid.
And then after the insurance ran out, and you're talking $2,000 a day. You go through a lot of different emotions. The biggest one is probably hopelessness.
The Reckawegs were finally able to get some help from Medicaid after they spent everything they had. Still, for the rest of their lives, they'll be paying off the $600,000 they owe for bills their insurance didn't cover. The problems faced by people who have insurance can be terrible, but for people who have no insurance, for whatever reason, things are even worse.
We thought we had health insurance. We didn't find out we didn't have no health insurance until the place closed down, until we investigated.
Bobby Simpson worked 14 years for a company that made truck bodies. But then the company was sold, and things went bad.
Christmas was rough because we all, got lost our jobs. December the 18th is when the place closed down, and nobody had no money.
When Bobby Simpson lost his job, he lost his health insurance. And to make things worse, he learned that even before the plant closed down, his employer had stopped paying for the employees' health insurance. So some of the Simpson family's medical bills that should have been covered by insurance weren't.
My oldest daughter's name is Stacy. She's 12. My middle son is Robert. He's 10. And my youngest son is Richard. He's 6. It's hard for kids to understand. They went to the doctors. Robbie, he went at least 6 times to get examinations and all, during when their insurance was supposed to be covered, but it wasn't. I had to file bankruptcy because I couldn't afford to pay anything else.
When you're not insured, or when your insurance isn't complete enough, you sometimes put off seeing a doctor because you're afraid you can't afford it.
As a nurse, my feelings are frustration and anger.
Valerie Gonzalez is a registered nurse.
I see people come into the hospital who are terribly ill and whose conditions could have been prevented.
Nurse Gonzalez talks about a patient with high blood pressure. With proper care, it should have been controllable.
Unfortunately, he was not able to go to the clinic on a routine basis. He ran out of his medications, and he suffered a stroke. And here's a 40-year-old guy. He's paralyzed on one side. He's having difficulty speaking. He can't feed himself. He can't bathe himself. He can't hold his urine. And that's a tragedy. And that makes me sad, and it makes me angry, and it makes me frustrated.
My husband, Charles, has Alzheimer's disease, and I take care of him myself. I change him. I bathe him. My husband is in Southern Hospital. It was 3 weeks ago, Friday, that he went in.
Mrs. Curtin wants to keep her husband at home, but it's getting expensive.
I have to find somebody to help me, to come in and help me to hold him, you know, and bathe him and help me. And if you do find people, they want a lot of money, which I cannot afford. I've talked to one woman that she told me that she charges anywhere from $9 an hour to $13 an hour.
Neither Medicare nor Medicaid will help her by paying for a caregiver to visit her home. And a nursing home now costs an average of $30,000 a year, or much more in big cities. Medicare won't pay for this. Medicaid will pay for nursing home care, but only after you've spent almost every penny of your entire life savings.
We have approximately 19 employees on our health insurance plan.
Margaret Ross is an administrator who looks after the needs of employees in offices in 2 states.
In 1988, we paid an average of $222 per month per employee for health insurance coverage. In 1990, for the same health insurance coverage, we're paying an average of $548 per employee. It wreaks havoc with the employer's budget.
In the first year, I went to get health insurance for my employees, and we secured a plan, and I had a game plan.
George Morley started up his own masonry contracting business after working his way up from laborer to apprentice to bricklayer. At first, his capital funds were limited.
So I said, well, I'll get health insurance for just the employees, and then next year, hopefully we'll be a little bit better on our feet, and then we can expand that coverage to cover their spouses and children and so forth. Well, in the first year, the rate went up 15%. In the second year, the cost went up again, this time between 30 and 35%. It's made it all but impossible to extend that coverage to my employees' dependents.
It's really a problem. It's a problem for the employee who wants to feel like his employer cares about him and is going to be there and take care of the things that he promised. And it's a problem for the employer who wants to do that and is finding that economically he can't.
Jim earns about $9 an hour. They don't come any better than he is. He had twin daughters, and they got sick. You know, twins, one gets sick, the other gets sick, and everybody gets sick. So he had some heavy medical bills. Well, he was covered, but they weren't because he was a laborer. He didn't have the kind of money it took to pay the premiums. These are real people who do a really tough job, and I don't know anybody who's any better in the world than these guys. Nobody who works that hard should have to come home and face something like that.
We reach a point as employers where health insurance costs are such a high proportion of our budget that we cannot continue to operate.
It's not just small business that's hurting. Chrysler Corporation testified before Congress about how health care costs are hurting American competitiveness.
Americans spend about 40% more per capita on health care than the second most expensive country in the world. And we're well over 100% more expensive than Japan. My company's concerned. We must compete with foreign automakers who have a $300 to $500 per car advantage over us due to health care costs alone.
Karen Ignani is director of the Employee Benefits Department at the AFL-CIO.
Businesses are feeling the crunch, but it's the workers that bear the burdens. Premiums have increased, deductibles have increased, coinsurance has increased, and that's led to a real issue with respect to families about going to the doctors, buying medicine for their children, treating their elders, and it's led to devastating financial consequences in many cases.
We shouldn't have two classes of health care in this country.
Robert Brandon is a consumer activist. He's vice president of Citizen Action.
Your kids deserve the same quality of care as rich kids.
Most Americans aren't happy with the health care system. Maybe we should look at what other countries are doing. Our closest neighbor, Canada, shares much of our heritage and our democratic ideals. They've developed a health care system that's a lot like ours, and very different from the British and European systems. But the Canadians avoided some of our biggest problems.
In the United States, we have private health insurance. In Canada, they have national health insurance. And that means everybody has insurance, the rich, the poor, and the middle class alike. You can go to the doctor and the hospital just like you do in the United States, but the difference is everybody pays taxes and everybody is protected.
Dr. Alan Detsky is a practicing internist in Toronto. He's also a professor at the University of Toronto. Dr. Detsky has a medical degree from Harvard and a doctorate in health economics from MIT.
Canadian healthcare system is extremely easy for both patients and practitioners to use. If you required medical care, you would show up at the doctor's office or at the hospital. You would have with you your insurance number, and even if you didn't have your insurance number with you, they would tell you to call it in the next day. Clinician doesn't have to think about what type of insurance you have. He will deal with your clinical condition. There will be no discussion of fees. You don't have to worry about that. You don't have to worry about paying anything out of pocket, and he doesn't have to worry about collecting it because he knows he will. You could use any doctor and any number of doctors. If you didn't like what you heard the first time, you could go and see somebody else. There's no barriers to access.
Canadian doctors don't have to deal with 1,000 different insurance companies to get permission before treating their patients.
There's very little of that kind of intrusion into the clinical world in Canada, and clinicians like it that way.
In Canada, like the United States, a lot of progress is being made in the technology of medicine. At Toronto Hospital, where Dr. Detsky practices, lung transplants were pioneered. In Canada, as in the United States, there are waiting lines in some places for certain procedures. But in Canada, the decisions about who goes to the head of the line are made by your doctor, not by the insurance companies. And nobody has to choose the quality of their health care on the basis of whether they are rich enough to afford the best.
The quality of care is excellent. Life expectancy has increased in both countries from 1960 till 1990. It's increased more in Canada than in the United States. Infant mortality rates are much lower in Canada than in the United States. The death rates from cardiac disease are lower in Canada than in the United States.
While providing top-quality health care for all Canadians, not just the rich, Canada has made important strides in controlling costs. By avoiding duplication of technology and cutting out the insurance middlemen, Canada gets good value for its insurance dollar. Robert Brandon explains.
It used to be that the United States and Canada spent about the same amount of money as a percentage of GNP on health care. They adopted a national health care plan, and we chose to stick with the private insurance companies. Today, that means that Canada spends about 8.5% of their GNP on health care, while we spend well over 11%.
The United States spends 1/3 more on health care per person than Canadians spend. Because there are no private insurance companies taking a cut, Canadians' medical bills don't include money for insurance company profits, advertising, or sales commissions.
We spend about 23% of our health care dollar in overhead compared to 13% in Canada.
Dr. August practices medicine in Maryland, just outside of Washington, D.C.
We have to fill out many times what's called a certificate of medical necessity in order to provide the insurance company with the necessary data so they can assess whether the claim is valid or not. Some practices have actually hired a person just to deal with the paperwork of the insurance companies.
In Canada, there is better planning for using high-tech machines and procedures. The Canadians have avoided the spread of high technology to hospitals that don't do enough of these procedures to do them right every time. They've decided that everybody, whatever your income or wherever you live, everybody who needs high-tech medicine should get it at one of the finest hospitals where quality control is best.
Perhaps the most important feature of the Canadian system is that everybody is protected. You don't have to worry about whether you can afford the care you need when you're pregnant, or the doctor's charges for writing a prescription for your child, or the cost of an operation for your mother. What Canada can teach us is that we can provide all our citizens with high-quality health care while still keeping costs under control. If Canada can do this, so can the United States. We can have a better American healthcare system by building upon our strengths and learning from what has worked well in other places.
In my opinion, as a human being, healthcare is a right, and everybody should have equal access to the variety of healthcare that's available.
The United States became great because we work together for the good of all of us. Taking action now to protect every American from the health care crisis would follow in the tradition of great American ideas like Social Security and Medicare. If you believe that your mother and father, your neighbors, and your children shouldn't have to worry about whether they can afford the highest quality health care, the care they need, you have to make this a political issue.
You're going to have to involve candidates in ways that put them on the spot. And what you have to, in effect, tell them is that if you're not going to vote for my family's health, I'm not going to vote for your political health.
If you feel that we should have a good medical system, you need to talk to your congressman. You need to talk to your senators and write to your senators.
We have to tell our leaders that we need a healthcare system that people can depend on without driving businesses into bankruptcy.
And don't stop with federal politicians. Tell your governor and other state officials you want action. If we can get 1 or 2 states to lead the way by providing health care for all, perhaps that will create the kind of pressure we need for action at the federal level.
Send this message to every candidate, from the State House to the White House. Our first priority for the 1990s is a healthy America.
Nobody should never, not have to worry about paying a doctor bill. If the government can go out and spend $500 for a hammer and $300 for a toilet seat, they sure in the hell can pay for people's health insurance.
If enough people in this country will stand up and take a stand, eventually enough people get their voices heard, they can't be ignored.
We got to tell people this is not a privilege. Don't act like, they're giving you something. This is your right as an American citizen.
This land was made for you and me.
Well, that certainly was interesting. Do either of you have a statement you'd like to make in response to the video?
Yes, I would just like to say that we think it really points out the problems that are facing us today in the healthcare industry. And our organization has made national health care for all Americans a priority for the last several years. And this last session of the legislature, we got a resolution through SJR 9, which sends a message to our people in Congress that Montana citizens want a national health care system, or national health care plan with a one-payer system, and which includes long-term care. And this resolution passed by a very large majority in both houses. So we feel it's sending a message, and we hope that they listen.
Have any other states done resolutions like this?
As far as we know, we are the first state to do this. Oregon is presenting one to their legislature. They call it a memorial, pardon me, a memorial, but it's calling for the same thing, calling on Congress to pass a national health care system. But we do believe we are the first to take this route.
Pat?
I think that, the specifics of what exact detailed piece of legislation are such that we think this is the first approach like Montana's, but we know that at least 10 states have begun the process of requesting waivers from the federal government to begin to experiment with health care within the borders of their states, acknowledging the crisis, not sure what direction to take without the lead of the federal government. They've requested that they, in fact, try something on their own. So we know there are at least 10, perhaps 11 states that are trying to do something besides inviting the national government to assist us.
Mm-hmm. Doug, since this proclamation came from the Montana Senior Citizens Association, how does this plan specifically apply to seniors and the elderly in the United States?
Well, I would imagine you would do away with like Medicare and Medicaid, and we would all be under the same system, seniors as well as
regardless of your age, you would all be under the same system.
Yes.
And you see this as an advantage to seniors rather than being segregated to your own system?
I certainly do, because there are a number of things now that Medicare does not cover, and a lot of times you have supplemental insurance and it will not cover it. So we feel it would be an advantage to all of us. And of course, the younger generation, many of them have no insurance, so it would be even more of a benefit to them.
In the video, they spoke quite a bit about the program in Canada. How does the Canadian health system work, and is this a model for which we could look for the United States?
Go ahead, Pat.
I think that Americans don't like to copy anybody. The concept of saying we want a Canadian system, I can see it sticking in the craw of people who even say the words. So what I think, what many who are working toward healthcare reform are speaking are the words that say there are principles of the Canadian system that we would really like to see as cornerstones of an American program for national health care. And the principles of the Canadian program that we most would like to import are the concepts of single payer. That is, there would be one payment system. Right now we have 1,500 different payers, 1,500 different insurance companies, plus Champus, plus the VA, plus Medicare, plus Medicaid, plus the Indian Health Service. That in essence what we would do is we would have a single payer as the first principle. The second principle would be that it would be universal. It would cover everybody. Just as Doug said, it wouldn't categorically define who it would see. For example, right now we have categorical medical programs that see seniors or disabled people or people who are interested in family planning or people who are under-immunized or who are refugee populations. In a universal system, all of those people would be washed together. And the third principle is comprehensiveness. And that is something that the Canadians have defined within their system to not include long-term care, or at this time, a comprehensive program for Canadian people includes a variety, a package, a menu of services, but they have not rolled in long-term care. What we believe would be a critical piece of that comprehensive package would be long-term care if it were exported to the United States.
Then if a Canadian needed long-term care, they would have to pay for it themselves, or would they have to buy private insurance to provide for it?
At the present, they would be able to buy private insurance because it is not a part of the Canadian healthcare system. There are a number of things that I believe, like glasses and dentures, that are not covered, and you may buy private insurance for that. But for anything covered by the Canadian National Plan, insurance companies are not allowed to sell insurance for those things.
Let's say I'm to play devil's advocate here. Aren't we talking about socialized medicine, and isn't that somewhat contrary to the American way of life?
We're not talking about socialized medicine. We're talking about a social insurance program, a national. This is what Medicare is now, is a national insurance program. And certainly I don't believe it's being called nationalized medicine.
All right.
Could I make another comment about socialized? I think that, once again, sometimes that word is used with a slight curl to the upper lip. I think you only have to look at our system of education in this country. Many would call that socialized for the welfare of all. Our highway system, in which we receive federal funds to promote a system of roads for all. The spin that you put on the word socialized has a lot to do with your intent. If by socialized you mean for the benefit of all, then in fact we are proposing a socialized system of medicine.
Thank you.
The only socialized medicine we have in this country is the Veterans Program. This is where the government builds the hospitals, hires the doctors, and this is socialized medicine, but that's the only group that has it in this country.
Isn't it perhaps a little unrealistic to imagine the dismantling of such an enormous business, which is the private insurance, health insurance companies, entirely dismantling them to develop an entire government bureaucracy, especially under a Republican administration? Is it realistic to assume that this is doable?
That's a difficult question, but I think it probably will be hard to get it through under at least the present Republican administration. But however, the outcry in the country is becoming so great that I think that they may even have to give a little on this issue, because people are beginning to demand that something be done, not only citizens, but doctors and businesses as well. Say we have to do something, and we have to do it soon.
So does big business feel that this is a role that government should be taking?
Yes, they do. Representative Pat Williams, talking to a group of us seniors last year, said that one of the officials of the Ford Motor Company was in talking to Tom Foley, the Speaker of the House, and talking about health care. And he said, if you come up with a good national health care plan, I can guarantee that 20 of the largest corporations in the country will be behind it. And Pat Foley said, well, why are you in favor of a national health care plan? And he said, well, at the present, the cost of insurance for our employees, it costs us more than the steel for our automobiles. And of course, Leah Iacocca has been long saying this for a number of years, that it's adding $700 or $800 to the cost of a car, where in Canada it's between $200 and $300.
So if I were to go out and buy a car, I'd be spending more money on that car to provide health insurance for the people who made the car than I would be paying for the steel that went into that car?
That's correct. And big business feels that they cannot be competitive when they have to put this much money out for health insurance for their employees.
Well, if big business would be willing to support a program like this, how does the average American feel about it?
Well, for now, a long time, a great number of years now, polls that have been taken showing that the American people, by 65 to 70%, are in favor of a national health care plan, and many of them say they would be willing to pay more in taxes to get such a plan.
Well, that's an obvious segue when we talk about taxes. It obviously means that this would involve an increase in our taxes. Would that increase in our taxes be outweighed by the reduction in cost in what we have to pay in insurance premiums and health care and the costs of overhead for all of these insurance companies? How does that balance out to the consumer?
We'll let Pat answer that, because the organization she belongs to has done quite a study on that and come up with a paper on that.
I think that I'd like to backtrack a little bit to see how we got here. and just to say that I think current estimates suggest that the insurance industry, the trade, the insurance industry, only approximately 18 to 25% of their current revenues come from the health insurance component. So the sense of dismantling may need to be modified to a chink being made in it. So we're not asking, if the assumption that you're making, I assume, is one that we heard from the video that we saw today, that health insurance, private health insurance, is something that will have to go. It is not the predominant cornerstone of health insurance revenues in this country. And that the business support we're seeing nationally, the American Leadership Commission, which is a trades group of big companies like Chrysler and Ford, is incrementally moving toward approval of a single-payer universal comprehensive program, which in essence achieves cost savings by eliminating all of the administrative costs. So now to kind of come back to what you've said in terms of the T word, taxes. Let's assume that once health insurance does not become a free market commodity in which you have accounting costs and you have marketing costs and you have a variety of administrative costs that go along with a marketed commodity, you achieve a tremendous savings. And as Doug alluded, the Physicians for a National Health Program group of economists who have studied this, and we understand that the General Accounting Office is auditing the PNHP proposal to see if in fact the numbers are correct, and that will be out sometime in the next 6 months, that there is in fact cost savings occurred in the neighborhood of 15 to 20% times 660 billion, and you see that the 60 billion price tag that we see from the Pepper Commission and others which say that's what's needed to improve the system, that could be achieved in savings alone. So if in fact American healthcare is somewhat of a shell game, there's a certain shell that has $60 billion. Putting that back into the system would allow us to promote access. Decreasing the number of payers involved gets us in a position to control some costs. Now the T word again, now getting back into taxes. What we know in Canada is that at this time, when we look at the piece of pie of money paid for Canadian healthcare system, we know that roughly 66% comes from the provinces, and 30% comes from the federal government. Right now, 30% of our health dollars are borne by the federal government. All the rest of us make up the remaining 66%, 67%. And so how people pay for health care right now is very much hidden. When you pay state and local taxes, you don't see that, I mean, if every man and woman in this country were to be truly taxed for the $2,500 per capita we pay to provide health care for everyone, few of us would reach into our pocket and roll out $2,500 bills. Mm-hmm. We don't feel the impact of the costs right now. What we do is we have higher local taxes, we pay higher dollar amounts for goods. Our medical costs are buried. We don't really see what is paid for health care. And so the tax or the premium, as the Canadians pay, would be very much more clear-cut. And that gets back to your original question. Would it be made up for by the savings that we achieve elsewhere? All the recent studies and economic projections agree that, in fact, it would.
Getting back to something you said quite a bit earlier when you said that the health insurance companies, that their income from premiums was not a large percentage of their income. What is their other source of income?
Well, only 18% of their business is in health insurance.
In health insurance income or health insurance entirely?
18% of their insurance is in the health insurance business.
Mm-hmm.
So
of their business revenues come from health insurance dollars.
I see.
82% is from other life insurance and all other types of insurance. So it's not really that big an item. And some of the insurance companies, they say, are now asking themselves in boardroom meetings, why are we in this business to begin with? Because it is fairly recent. In the insurance business, the health insurance is a fairly recent phenomenon.
How does the AMA feel about all this?
About what in particular?
Well, about this proposition to have a national health care program with a single payer and universal health care. Do they support this? Are they opposed to it? What's up with them?
I think politically, if there is a PNHP proposal, which is modeled after the Canadian principles, there is an AMA proposal called Health Access America, which is in fact very similar to the Pepper Commission recommendations. What many people see as a problem with the AMA proposal is that it's a short-term solution, that healthcare costs in the United States are a runaway train. Many of us are beginning to see that. We're seeing incremental increases in the GNP going to provide services for fewer and fewer people. And so many of the proposals that have been put forth in the short term may solve the problem for a decade. As as was the problem with Medicaid and Medicare. In the 60s, when this legislation was passed, everyone thought this would fix the system. We now see 20 years down the road, it didn't fix it. It created its own set of problems. And so the proposals put forth by other groups, which are to continually try to patch and fix and hold the current existing system together, may in fact work for a while, but don't have the long-term potential for increasing cost containment and also increasing access.
They're pretty much Band-Aid approaches, and as I view those programs, it would lead to even greater bureaucracy and paperwork than we have now.
If that's possible.
Does this project provide the same impetus, the same encouragement for young people to become physicians or go into medical services that currently exist in the United States?
I think so, because physicians are getting probably more fed up with paperwork now than anyone else. And I think younger people going into this, if they could look down the future and say, we will be free to practice as we wish, and we will not have the enormous amount of paperwork to do. We will not have to worry about collecting bills and losing 20% or more of our earnings to uncollected bills. So I think I would think they would welcome it with open arms. My sister, who is in San Diego, belongs to the Kaiser Permanente plan, which of course is a large HMO, but it works pretty much on that order. And her doctor down there said, I like it. My paycheck is there every month. I don't have to worry about collecting bills. I don't have to have a large office staff to do paperwork. I think while they may fight it to begin with, I think the mere thought that somebody is going to have some control is what bothers them the most. They like to feel that they're free to operate independently. But I think if they look at the long-range view of it, that they would see benefits.
There are those who've said that AIDS provides the ability to really break our healthcare system. And we're already seeing people being denied health care because they are HIV positive. How does this system deal with that enormous problem?
A system of national health insurance? And that's really a complex question. Let me see if I can break it up into different pieces and talk about it. Currently, the AIDS epidemic is largely localized in larger cities. And we also are seeing people being denied care for a variety of reasons, and that fits into the issue of categorical programs. But I think the last thing I want to talk about is the societal picture of how we deal with AIDS. The program that I think you're alluding to is a Canadian principled model, which is one put forth by the Physicians for National Health Program group. So I will talk as if that's what we're talking about. The way the PNHP proposal would operate would be like the Canadian provincial government, where the federal monies would disperse, the federal government would disperse monies to the states or provinces for them to deal with as they so wish. And there would be formula allocations. Obviously, a state like Montana would not have the same amount of money that a state like California would have. And so monies would be dispersed geographically, but to be used autonomously within the state. And we wouldn't have categorical programs. Right now, there are federal monies that come to Montana that are a pipeline for immunization monies, or a pipeline for disabilities money, or a pipeline for HIV testing, or a pipeline for family planning, that come from guidelines made at a federal level that we may not use unless we follow those federal mandates, and unless we match with funds according to those federal formulas. So right now we have a terribly bureaucratized health care pipeline of money coming from the federal governments, which ties our hands about dealing with AIDS patients. For example, if there were a new approved drug that doctors could in fact dispense, or maybe even an experimental drug, there is not money available to purchase that drug unless it fits in with federal guidelines that come to us from 2,000 miles away. So you can kind of see that the roadblocks in the AIDS system are legion and sometimes designed to seem like they're helping people. But I think the larger issue that we're all going to get to is the AIDS epidemic is a metaphor for what Doug alluded to earlier. We can, in this country, we can do almost anything. The issue is, can we pay for it, or do we want to? Or perhaps both of those questions are tied in. And I think societally, we've never had to address the issue of limited resources. If you just keep digging in your pocket or someone else's pocket. And part of a proposal in which we have finite amounts of our GNP allocated to healthcare demands that we begin to look at how do we want to spend that money. Do we want to spend it on long-term care? Do we want to spend it on premature babies? Do we want to spend it on contraception? Do we want to spend it on the AIDS epidemic? I think that's only something that we as a people can answer together. I don't think a policymaker will be in a position to make those positions. And a PNHP type proposal, the Canadian principled proposal, encourages the provinces to make those regional and autonomous decisions.
I would be concerned with the concept of states being able to decide how they'd spend their money, because there are some states, which will remain nameless, which might choose to be quite punitive in how they offer medical care. They might say HIV positive and you live in our state, too bad. Pregnant teenage mother, unmarried, tough. You know, there are consequences to your action and we're not going to pay for them. And legislatures have made goofier decisions than that in the past. How would we protect, when we do offer this money as block grants to states under this program, how would we protect the members of that state from the, you know, the winds of a legislature, the vicissitudes of morality, causing a sort of a patchwork quilt of care across this country?
Well, I think some of the national health plans that have been brought forth, and I'm not sure about the physician's plan, but I believe maybe that's the case, that your local control, like in your states, would be under a board made up with the majority of consumers, so the consumers would pretty much have quite a say in that. I think that is part of the answer as to how you control that, is to have the consumers well represented on these boards. I think that's protection.
But what if they were political appointees?
I think you've raised an issue that needs to be dealt with as we move in that direction. How do we want our state administrative boards constructed? Do we want political appointees? Do we want them to be elected? Do we want a combination? I think that issue, once again, raises societal questions that can only be answered, I think, as we live through them. We do know that the Canadian system, when it first was conceived, had a very laissez-faire attitude towards the provinces. As long as they used a single payment board and were universal and comprehensive and allowed any Canadian system of any province to obtain the coverage that they could get in their home state if they traveled elsewhere, so that there was reciprocity provided for lessening of some of that patchwork that you've discussed.
Okay. You brought up earlier, and we should be sort of wrapping this up, limits to care. That when there's a finite amount of money, decisions have to be made regarding a finite amount of care, or when to stop. For instance, in the video we saw that story about that little boy who had the breathing problem, and they'd spent $600,000. At what point would this system, or maybe, or in some other very, equally tragic case, would this system say, stop, we're pouring a lot of money into this one individual without a reasonable assumption of improvement or even improved quality of life? When do we want the government to start playing God?
This, of course, as it also showed in that outside of the nights when he is asleep, he's a perfectly normal, healthy person. It would seem a shame that you would pull the plug on someone that could lead a otherwise very productive life. And when you talk about limitations, we're talking about somebody that has very little hope of living over a few months or a year, say if it's the elderly, and like some premature babies that are saved are nothing but expense down the road, of course, and they never really do have a healthful life. But these are problems that have to be decided, and there's always going to be controversy over these, I would imagine.
Sure. I would just like to add to Doug's comment and say that we can do so much now. We're in a position to say, and we weren't a generation ago, shall we or shan't we? Now we can. And the matter is just the expense. Can we spare the expense? In the process of putting on talks around the state and listening to people, and certainly this is a major issue, one of the things that I think we've heard people, we know statistically that something like 70% of healthcare dollars are spent in the last 30 days of anyone's life, so that we know extreme amounts of money are put forth when one is an extremis, in the terminal event of one's life. What we've also heard is, we've heard people stand up at symposia or conferences in town and say, if I had to give up my last 30 days in a rest home on a respirator in exchange for my grandson's heart surgery, I'd do it in a minute. Right now, because there are so many different players, so many different rules, so many different guidelines, so many different eligibility determinations, the landscape isn't clear. The great equalizer isn't there. What we do have a sense of is that if all of us were playing by the same rules, it would be clear what we were giving up and what we were getting. And once again, we don't have that option as a society now because there's so much that's not evident and not clear. We think that this approach would make decision-making about what we can do and what we can't do much more straightforward and direct.
This is why so many of the seniors across the country now are signing living wills, and also adding to that a durable power of attorney to make sure that their wishes are carried out in these living wills.
What should we ask of our elected officials, our politicians, our members of Congress? What should we ask them to do on this, if we indeed support this kind of program, or if we want them to let us know how they feel on it?
Well, I think we have to let them know that the public is tired of waiting for them to do something. This is why a number of the states are going off on their own, and I really hate to see that, because then you've got a conglomeration of different kinds of programs. But I think is to let them know that we need this and that we can afford it by having a system, a one-payer system, and controlling cost.
I think, and that may be a time for us to talk about actions that have been taken. I think that what we're hoping is that the sense of the loss of power and activity and spirit, the involvement of the general man or woman on the street has been lost, that we'd encourage them to see that there are some principles in the solution that we think need to be explored. The concept of having a single payer, having it cover everyone for everything that's medically necessary, are the principles that we'd like our lawmakers and decision makers to start to look at. There's a current bill in Congress put forth by Representative Marty Russo from Illinois that's currently in committee that approaches that kind of bill. We know there will be others. Our decision makers need to hear that we've informed ourselves on the issues, and we think there are certain principles that need to be acted upon.
And persuade them that we believe that health care is a right and not a privilege. It is a right in most countries. Industrialized countries, is written right into their constitutions, and we believe that we should have the same.
It's not a right in our national constitution. Is it a right in our Montana constitution?
I don't know that.
I can't really tell you.
Let's segue a little bit. We've got a few minutes left to an issue that's of particular interest to me. I've been shocked to read that the United States has one of the highest, if not the highest, infant mortality rate in the whole entire developed world. How could this program that you're proposing deal with that, I think, very shameful piece of information?
Want me to go? The steps to, during the time that I worked for the health department here locally, I was very involved with a program called Access Links that assisted low-income women to get early prenatal care. I think that we have to backtrack a little bit and say that currently American people don't have health care unless they have a ticket. Many people of childbearing age do not have a ticket, which includes comprehensive maternity coverage. So they're in a gap period. They may be employed, they may both be employed, they may have good medical coverage, but they don't have maternity coverage, or they don't have maternity coverage that kicks in until in the middle of pregnancy. We know that the system of private insurance discourages early prenatal care. And anyone who follows maternal and child health issues knows that early intervention is the name of the game in so many congenital and maternal and fetal problems. So we think that the structural, organizational details of our system, as it plays out in the United States right now, is directly related to the roadblocks to entrance into early prenatal care. We know in Canada that they have twice the entrance of women in their first trimester to prenatal care. And we think that's because of the easy access afforded in a system where you have a ticket. You're guaranteed to have a ticket. You don't have to buy one.
Well, we need to wrap up now. I was wondering if either of you had any closing statements you'd like to make.
Well, I would just, excuse me, like to say that I believe we are having some impact on our legislators. I ask our legislators who have offices in Missoula, our Washington legislators, to give me their reaction to our resolution. And I have a letter from both Max and from Pat Williams. And here's what Senator Baca said: we should have a single-payer system to cut down on administrative costs and the paperwork burdens we suffer with. We should have universal health care. It is unconscionable that we do not now. We should have a strong cost containment and incentives for practicing in rural areas and for practicing primary care. These are some of the features of Canada's system that are superior to ours. And Representative Williams goes on and points out all the problems we have been having. And he said, you can count on my support and commitment to the resolution of this critical problem. So I think they're beginning to listen to us. We've been talking to them for a number of years on this, and we feel we're making progress.
In the interest of continuing the dialogue and the debate, I'd like to remind you and others that the University of Montana and a group of communities, agencies, have agreed to put on a symposium on healthcare reform. And the title of that symposium is U.S. Healthcare Condition Critical, and it will happen September 12th, 13th, and 14th. We've attracted some national speakers to come and help us study this issue and become fully informed so we can decide those next steps.
Well, that sounds very interesting. We're looking forward to that. Thank you both very much. We've had Dr. Pat Hennessy and Doug Campbell, and I'm Deborah Franson, and thank you all very much.
Well, thank you, Deborah.
Thanks.